Thanks.
Recording in progress.
Good evening. Welcome to tonight's AO Trauma Hand North America online webinar entitled 3 Cases Fireside Series. Tonight's topic, ulnar-sided wrist pain. Our chair for our series and for the Hand Education Committee for AO North America Hand is Marco Rizzo from Mayo Clinic. And I'm Jay Bridgeman from Columbia, Missouri. And I'm excited to have our other invited faculty is Jeffrey Yao from Stanford University, Jerry Wang from University of Washington Medical Center, and thankful to have our therapy person tonight is Wendy Moore from Stanford University. Thank you everyone for contributing. These are our pertinent disclosures this evening that we want the audience to know about. And then our content validation statement. As AO North America, we're an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. We don't endorse or promote the use of any products or service of commercial entities, but really the equipment or techniques that we use in the course is generally for demonstration and teaching purposes with the intent to enhance the learning experience. We want you to know that you can receive CME credit for tonight's activity. It is a little over 11 Category 1 CME credit that you can get, but it's determined at the end of the series, which is in December. That's key to understand. So a link will be sent to you 24 hours after the conclusion of the series in December for an evaluation questionnaire. Upon completing the certificate, you can get your CME. Our Zoom etiquette tonight, all microphones have been muted and video cameras turned off. Please contribute by sending in questions to the question and answer box. Both myself as well as the other faculty will be looking through the questions depending on who's speaking, and then either answering back or bringing those up as discussion questions. So please be contributing. The chat box, though, is disabled. It's just essentially for the faculty and the staff. Our roadmap for tonight, I'm going to begin with kind of an overview of the diagnostic evaluation of people with ulnar-sided wrist pain. It's really a broader topic for an hour webinar, so we thought we would narrow that down. Dr. Yao will continue on with ulnar shortening osteotomy and ulnar impaction. Dr. Wang will talk about navigating complications. Wendy Moore will finish with therapy discussion and principles, and then we'll have some time at the end for more questions, trying to get done somewhere around between 8 and 8:15. These are the learner objectives for the webinar tonight. And as I said, this is a series. So this is the third topic in our series starting in January. Please keep track of these future dates. We do go into May for the spring. We take a break for the summer. You can see the dates starting back again in September through December, as well as the invited faculty. So we'd love you to be a part of our future sessions for the 3-case series of 2024. We also have standalone webinars that are not a part of the series that are free. So please keep track of those on your calendar. May 1st is finger flaps, soft tissue reconstruction. August 7th is both bone forearm fractures, followed in December, the distal radius malunion. And then our in-person courses upcoming in 24, the Fellows Hand Surgery course is at the end of May in San Diego. There's a 1-day hand and wrist fracture management course in Jersey City, New Jersey. And then our cadaver-based advanced upper extremity trauma and flap course, which is in November in Cincinnati, Ohio. So please keep us in mind. We'd love to have you join us for an in-person event. Tonight's webinar is being recorded, and you'll get a link to it for those who've registered within 24 hours for the recording. And then lastly, we want to thank OrthoTV, an online partner with us that they live stream the AO Trauma hand events all throughout the world. So we're thankful for OrthoTV and their partnership with our events. So with that, ulnar-sided wrist pain. Ulnar-sided wrist pain is a very challenging diagnostic problem with our patients just because of the variety of reasons that it might come to us with ulnar side wrist pain. People have described it as the black box of the wrist, or others have said that this is like low back pain for the wrist or for the hand surgeon, just indicating it's difficult to diagnose. The treatment may be a quandary of what's the correct treatment for the pain that they're having, and that are concerned that they may not improve. But really, when you take it down to a more basic level, it's related to the complex anatomy of the ulnar side of the wrist. And so it requires an extensive knowledge and fundamental knowledge of the complex anatomy as well as the differential diagnosis of the pathologies that can occur there. This is just one list in a JAOS review article, just going through the known pathologies from ligamentous categories, the TFCC, intrinsic ligament tears like lunotriquetral ligament tears or ulnar triquetral ligament tears, osseous abnormalities such as Hooker hamate fracture, pisotriquetral arthritis, DRUJ arthritis. But don't forget even things that as broad as vascular abnormalities, ulnar artery thrombosis, neuropathy at Guillen's canal, and then as well as extrinsic. They're not always within the wrist. Even the extrinsic tendons such as ECU instability, ECU tendonitis can play a role. When we think about the diagnosis and the workup, really you can categorize patients into one of three. Have ulnar-sided wrist pain, you would like to know, is there also associated DRUJ instability? Most have ulnar-sided wrist pain, the DRUJ is stable. Some patients have ulnar-sided wrist pain with DRUJ instability. And then the last category would be ulnar-sided wrist pain and arthrosis. The other thing that I think about when taking a good history is really determining from the patient, where is the pain? So we all think about, is it acute? Is it chronic? What was the mechanism of injury? What's a description of the type of pain that they have? How do they experience pain? What activities reproduces it? But when I think about the wrist and where patients are having pain, I'm trying to narrow down what quadrant their pain is. If it's ulnar-sided, is it straight ulnar? Is it ulnar volar? Is it dorsal ulnar? That can be very helpful to help narrow down the differential as well. But I think the most important step in the workup is the physical exam. Certainly, I've had patients come to see me who've already had multiple tests, and MRI's already been ordered, but there wasn't any real decision making that was based on a differential diagnosis when they come to see me. So instead of ordering tests, what we want to really think about is let's order a physical exam. You can say that. Certainly, when we think about the exam, the abnormalities on inspection, the palpation is key. Like, where are they having? Can you reproduce their pain? I tend to try to come up with a differential diagnosis in my mind before I get to the physical exam, because I want to try to elicit pain, but go there last. The idea with the provocative test is that we can rule out those things that were normal, rule in those things that were abnormal. And then can we get an understanding, is this an extracapsular process or is it an intracapsular process? So this is a list of the provocative tests that are very helpful for ulnar-sided wrist pain from Brogan et al. From a JBJS review in 2019, which I think is really well written and describes these clearly. We don't have time to go through all the tests this evening, but the two that I've put here just as pictures include ECU synergy test, which is with abduction of the thumb and the middle finger against resistance. The ECU will fire in that setting. And so if they have tendonitis or it creates stress across the ECU, that'll elicit pain, helping you narrow down to the ECU. The second picture there with the green arrow is the piano key test of looking at DRUJ stability. The examiner is stabilizing the radius with the left hand and then creating dorsal volar translation of the ulna at the sigmoid notch, looking for instability, and then testing that in three positions: supination, pronation, and neutral. And then it's key that you are using the other wrist as a control, that you're getting a good exam on both wrists can be helpful and key. Just the second half of this list, I won't go through all of these, but just as a reminder that we really want to think outside of just the musculoskeletal bone and joint instability, ligament ideas. We want to consider also a thorough neuro exam. We want to consider things looking at any arterial abnormalities such as the Allen test are important to remember as well. For imaging, the hallmark baseline would be well-obtained standardized radiographs. We know that in different forearm positions, it can create abnormalities in, for example, ulnar variants. So for the true AP, we want to have the shoulder abducted and the elbow at 90 degrees, just to be certain that the forearm is in a neutral position when the PA radiograph is taken. In the pronation position, we know that the radius will shorten and give us a falsely positive ulnar variance, or increase the ulnar variance relative to the radius in a pronated position. And grip views also do that. The true lateral is one in which we can standardize and know it's well taken by looking at the position of the pisiform as it overlaps the scaphoid. The borders of the pisiform should be at the volar aspect of the cortex of the capitate, but also not quite over the volar cortex of the scaphoid. So between those two lines is where the pisiform should be in good position for a true lateral, otherwise indicating there was rotation when the lateral was taken. But all of these are designed so that we can measure accurately if there are abnormalities, for example, in dorsal translation of the ulna, that we're not seeing actually a rotation of the wrist. The specialized views, there are many, but two that come to mind are the carpal tunnel view, looking at for hook of hamate fracture, a volar supinated oblique, looking at pisotriquetral joint to look for arthrosis. And then, just like the physical exam, getting comparison views can be very helpful. Now, with any an analysis of the carpal anatomy in areas around the wrist, for bony anatomy, the CT scan is much more helpful, just because of for example, the overlap of the carpal bones on the lateral radiograph. So a CT scan can be very helpful, especially looking at bony anatomy or subtle fractures or subtle subluxation, looking for arthrosis. Another series that is very helpful at looking at DRUJ instability is this DRUJ comparison series. It's not two complete CTs of each wrist. It's just the axial views at the DRUJ, at the sigmoid notch, in three positions: supination, neutral, and pronation. So this protocol is very helpful. And you can see in this bottom right view that the wrist on the bottom right, you can see dorsal subluxation of the ulna at the sigmoid notch in comparison to the opposite side. Now, going on to MRI, we do know that it's highly sensitive and specific for looking at the TFCC injury. It doesn't have as high specificity in telling us the location of the injury, but that's improving with higher magnification, higher power magnets, like the 3 Tesla coil. They have improved specificity for those types of TFCC injuries. But we always want to be thinking that even in MRI series of patients that were asymptomatic, especially in older patients, they had a high rate of patients with an abnormal signal in the TFCC without any symptoms. So again, that's where it's really helpful to have a very thorough workup and differential diagnosis, so that you're not drawn away from these incidental findings on the MRI. That you're thinking about the MRI as an aid to decision making. It is not the decision; it's an aid to decision making. The last two views there on the bottom, it's not uncommon that patients are referred to me for a Keen box, and it's actually ulnar impaction. And the MRI view there on the bottom right shows edema just at the ulnar proximal aspect of the lunate, indicating impaction, but there's no edema throughout the lunate, and the lunate morphology is intact, versus the MRI on the left, which shows edema throughout the lunate, very narrowed lunate or loss of morphology of the lunate, indicating some collapse consistent more with Keen box. So that can be helpful. The MRI can be helpful in delineating those two diagnoses. Diagnostic arthroscopy, we know, is the gold standard for decision-making in TFCC treatment. So identifying the type of tear, the location, would it be beneficial for debridement or for repair based on the type of tear? But in the absence of a clear diagnosis, like when should diagnostic arthroscopy be pursued? Well, we know that a high number of patients that see us for ulnar side of wrist pain are up to 25% are extracapsular. So again, that differential diagnosis, we really want to get to a level where we are, based on the evidence we have in clinic and seeing the patients, that we think it's an intracapsular, at least an intracapsular diagnosis, such as a TFCC tear, or lunotriquetral ligament tear, as an example, to guide us for the decision for diagnostic arthroscopy. And then lastly, just a quick comment about non-operative treatment. Most of the patients that it's most common that they have ulnar-sided wrist pain, stable DREJ, no arthrosis. And they not only can be treated successfully with non-operative treatment, but it can be helpful even in the diagnosis. So immobilization, a daily NSAID regimen, 6 to 12 weeks, and then a corticosteroid injection. Not all of my patients want a corticosteroid injection at the first appointment, but sometimes that's helpful even, because when they come back after having had some immobilization and NSAID treatment, we can also, each time they're in the office, we can do another exam, getting more information from repeated exams and getting more accurate with the exam. But certainly, even with the corticosteroid injection, when given with some local anesthesia, it can also aid in the diagnosis, because if the location that you're anticipating, so for example, what I've the pictures here are an ulnar foveal injection for TFCC pain right in the ulnar fovea. When the local anesthetic that's given alongside the corticosteroid injection is working, even before they leave the office, we can go back and do a provocative test again and see if that's improved, also giving more information with the diagnosis. So with that, I'm going to, these are my references for the things that we discussed tonight, and I'm going to transfer over to Dr. Yao.
All right, Jay, thank you so much. Can you see my screen okay?
Yeah, looks good.
Awesome. Well, thanks for that great overview, and thanks for the invitation from the AO to participate in this webinar. I think it's a great topic. It's one of my favorite topics because I do think we have good ways of treating this problem. I'm really honored to be called the sage for this. Usually the sage is the kind of the old guy, the old wise guy, and I guess those people were kind of otherwise, couldn't make it. So I guess they had to ask me. But it is a big honor to be asked to be the sage. So I'm going to focus on the ulnar shortening osteotomy and kind of the why it's so powerful. I think it's a really good kind of final common pathway for patients with ulnar side wrist pain for a number of different pathologies, most of which were very eloquently discussed by Dr. Bridgeman just now. So my disclosure slide. Okay, so I have a very similar beginning sequence to Dr. Bridgeman in terms of the ulnar side wrist pain, and a lot of people don't like this. They call it the back pain of the wrist, because it's a little bit of a black box. But I'll go on the record to say that I actually really like ulnar side wrist pain. I think if you're thoughtful about the diagnosis, you can really make good diagnoses and good treatment options for your patients. What can cause it? Jay went over this a little bit in terms of a bunch of different differential diagnoses, and the palmar side as well as the dorsal side. For the most part, though, particularly for this discussion, we'll focus on ulnar impaction syndrome and TFCC injuries, mostly because they're the most common. Jay went over this a little bit, but ulnar side wrist pain is very common. For TFCC pathology, it's usually due to a fall and an actually loaded and pronated wrist. It may be traumatic, however. These patients typically have pain with forced pronation or supination, and pain with gripping and ulnar deviation, usually wringing dry towels or holding a heavy frying pan and hypersupinating the wrist. These are great mechanisms to cause ulnar-sided wrist pain due to TFCC pathology. These are some of the physical exam maneuvers that were also discussed: the TFCC stress test, LT provocative exam to rule out any LT pathology. And you also want to test for the DREJ to make sure that the most salient or most common ulnar-sided wrist pain etiologies are evaluated and ruled in or ruled out. Jay went over the imaging, so I'll skip through this. When we talk about ulnar variance, we measure the variance based off the volar aspect of the distal radius, which on a true PA radiograph is the more proximal articular surface. If you could see my pointer, it's this articular surface. The one in the back is the dorsal articular surface. And so we draw a line tangential to that. And then where the ulna lies to that line is its variance. If it's at the level, it's considered neutral. If it's beyond that, it's considered positive. And then below that, it's considered ulnar negative variance. So that would be an ulnar negative variant right there. Here's a good example of an ulnar positive variant compared to an ulnar negative variant. And we know biomechanically that 80% of the force through the hand to the wrist is borne through the distal radius and 20% through the ulna. But that changes with variance. In other words, if there's an ulnar variance of plus 2 millimeters, that increases the load from 20% to 40%. And conversely, if there's a minus 2 ulnar variance, that amount of force drops to a mere 4% through the ulna. That force transmission also changes with dorsal angulation of the radius, and this is why when we have a distal radius fracture with greater than 10 to 20 degrees of angulation, we're concerned about the load that goes through the distal ulna, and that's why these should be corrected. So looking at TFCC injuries, Andy Palmer helped us classify these in 1989, and we classified them based on whether they were traumatic or degenerative. And for the purpose of this discussion, we're going to focus more on the degenerative tears. And these are typically due to repetitive loading of the TFCC, typically due to an ulnar positive variant, but you can see it in an ulnar neutral as well as an ulnar negative variant. I tell patients that it's kind of like having a carpet that you keep walking over and time again, and over time that carpet wears a little hole in the center of it, and that's what can happen to the TFCC with an ulnar positive variant as the ulna is pushing up on the TFCC. And these central defects can occur without symptoms. In fact, there was a study out of Greece a long time ago which showed that about 50% of patients over the age of 50 have some degree of TFCC perforation. So it certainly can come with age as well, atraumatically. And these tears involve a flap which interposes, and this causes continued pain despite non-operative treatment. And so here's a patient with an ulnar positive variant with an MRI, not a high quality MRI, but you could see the central TFC tear to the right of that arrow right there. So how do I treat these typically? Typically start non-surgically. I like to immobilize my patients in a cast for 4 weeks. If it's a peripheral tear, there is some potential for that to heal. We're talking more about central degenerative tears, but I still think it's reasonable to try to reduce the inflammation in the synovitis. Anti-inflammatory medications, if that fails, at modifying activity, trying to avoid the activities that tend to exacerbate the symptoms. Hand therapy modalities, which Wendy Moore is going to talk to us about. And also steroid injections can be used to help mitigate symptoms. But if that fails, then we're talking about surgical treatment. And here are the classification or the stages of the Palmer classification for class 2 tears. And it's basically increasing gradations in terms of the perforation or the wearing and thinning of the central disc of the TFCC, as well as involvement of the ulnar head, plus or minus the lunate triquetrum and the lunotriquetral ligament. So here's a patient with ulnar positive variants there. And again, with a MRI, you can see edema within the carpus, particularly the triquetrum on this patient, and a small a bit of edema on the proximal ulnar aspect of the lunate. And with that central TFC tear as well, with the discongruity, or incongruity, whatever the word is, between the peripheral portion and the radial attachment here, you can see a big gap there. So this consists with the central tear. We talked about the non-surgical treatment. If that all fails, then the surgical treatment, the wafer procedure, which was described by Felden, can be done either arthroscopic or open. And the concept there is we just remove the articular surface of the distal ulna, which articulates with the lunate and triquetrum. And by doing that, that offloads the TFC and offloads these bones as well. The benefits of this, you avoid other issues associated with ulnar shortening osteotomy, which we'll talk about in a moment. But the caveats to this are you disrupt the distal ulnar articular cartilage, which I never felt very good about. And it's limited to about 2 to 3 millimeters of shortening. And I'll go on the record to say that although I like to do a lot of things arthroscopically, this is one of my least favorite procedures to do arthroscopically. I just haven't been able to replicate the good results that have been described in the literature in my practice. So how's it done? Here's the scope in the 3-4 portal, looking over to the ulnar side. So this is a right wrist. And you can see the probes in the central TFCC tear. You start by using a biter and take away the central TFCC frayed area back to a healthy rim. And then you insert your shaver to further clean it up, and then use a burr to remove that corner of the distal ulna. And I have to thank David Auerbach for this video because, like I said, I don't typically do this procedure. So I have to thank him for giving me a copy of his video showing how it's done. So there you can see the ulnar head below, and we insert a burr and remove that distal radial cortex of the ulna. And if you look at the literature, the evidence is actually quite good. But if you look a little bit deeper, you'll notice that a lot of the literature is out of the same institutions. But not to throw shade, I do think it's a reasonable option. But again, in my hands, I haven't been able to get the same good results as I had with some of the other techniques that I'll describe in a moment. What about microfracture? This is not a new concept. This has obviously been done in the knee and other joints for a long time, but really wasn't well described in the wrist. And the concept is for isolated osteochondral defect, particularly with an ulnar impaction lesion, you can remove the loose cartilage, remove the calcified cartilage, and then create microperforations within the subchondral bone to allow some of the mesenchymal stem cells to elute out from the medullary canal of the bone, and then create a scar ball, a hematoma, and then followed by a scar ball, which would ultimately resurface your defect. So there's a lot of literature in the knee, and this marrow stimulation is what you're looking for to have that clot develop a fibrocartilaginous filling of your osteochondral defect. So here's a patient of mine. You can see there's a large osteochondral defect off of the lunate due to ulnar impaction syndrome. You want to debride that loose cartilage into the calcified cartilage, and then you can use microfracture awls to fracture through the subchondral bone. Here you can see an example of one of the awls with a laser line, which is about 2 millimeters away from the tip. And so you fracture, or you mallet that into the subchondral bone of the lunate in this particular case. We turn off the arthroscopic fluid, take down the tourniquet. You can see blood elutes out from the microfracture sites, and then that forms a clot. And then after the clot is formed, I like to immobilize my patients for about 6 weeks to let that mature, and then you start rehab. And here's a second look patient, that patient that I described earlier. You can see before and after, about 5 years after the microfracture. Now, that's not normal cartilage. I'm not saying it is, but it is fibrocartilage, and it resurfaces that. And that's better than having a large osteochondral defect, as you can see on the left-hand side. So we published on our experience, not a huge number of patients, but it's important to point out that their DASH score and PRWE score did go down, but it did not go to basically normal. So they did improve, but it wasn't a grand slam home run type of outcome. But most importantly, none of these patients ultimately required to go on to a secondary ulnar shortening or a wafer procedure. So these patients did fine at 2-year follow-up. But what about the ulnar shortening osteotomy? This is, again, one of my favorite procedures to do. It was first described by Milch in the 1940s. And it's a leveling of the radial ulnar articulation. This decompresses the ulnar carpal joint, but also tightens the ulnar extrinsic ligaments. That also helps stabilize the ulnar carpus. So again, these are causes of ulnar side wrist pain. And what can an ulnar shortening osteotomy treat? It can treat a large number of those issues. And so here's a patient, again, with ulnar positive variance. And then after the shortening osteotomy, you can see the variance has been restored to neutral. The caveats are not trivial. The non-union rates have been described from anywhere from 5 to 7%, particularly higher in patients who smoke or use NSAIDs. Patients often feel the plate on the subcutaneous border of the ulna. It could be painful. There's very little subcutaneous tissue cover on that side. So if you do this, attempt to place the plate volarly. And there's some theoretical risk if you have a reverse inclination of the sigmoid notch. So a normal sigmoid notch looks like the image here, but sometimes you'll have a sigmoid notch going the opposite direction. And the thought is that if you shorten the ulna, that the ulnar head won't sit congruently in the sigmoid notch. And in that case, you can do a sigmoid notch rotational osteotomy, which has been described to rotate the sigmoid notch back to match the ulnar head. But Mark Ross and others have shown that, in fact, although radiographically it may look like the sigmoid notch is in this position, there's a fibrocartilaginous labrum that helps seat the ulna regardless of the position. So their argument is that it doesn't matter if the patient is reversely inclined, and I tend to agree with that. If you look at the evidence, they're all quite good with this type of procedure. I do think it's a good final common pathway for ulnar impaction syndrome, chronic or acute TFCC injuries. In Korea, I spent some time in Korea observing some of the surgeries there, and they actually will just do an ulnar shortening osteotomy, not even scope, not even address the TFCC. If their patient's ulnar positive, they just do a shortening osteotomy and don't mess with anything inside the joint. So you can consider this for an acute injury as well. I do think it's a good common pathway for LT injuries, which I'll get to in a moment as well. And now with the newer implants that are available, this makes it much easier to perform. So we published on our experience on 30 patients with a minimum follow-up of 8 months, and you can see their outcomes measures are quite good. But we did have some complications, again, in line with the previous literature, non-unions of 7% and plate removals of 13%, so not trivial. So that led me down the road of thinking more about the distal metaphyseal ulnar shortening osteotomy. This was described by the late Joe Slade in the 2000s or mid-2000s, and Warren Hamron and Jeff Greenberg and others have also published on it. And the benefit of this, of creating your osteotomy in the metaphysis of the ulnar head, is that it decreases the risk of non-union because this is good, healthy metaphyseal bone as opposed to diaphyseal bone. And number two, you're using a screw which is implanted, so the risk of the hardware issues that we talked about with the diaphyseal ulnar shortening also is reduced. So there is potential benefit for both of those reasons, but I do think you're limited to about a 2 to 4 millimeter shortening with this metaphyseal shortening osteotomy. Here's one of our patients that was treated before and after with the metaphyseal shortening osteotomy. The question is it better to place it retrograde, as Dr. Slade initially described, or anterograde? And so we sought to look at this, and we did a biomechanical study looking at this, where we created a closing wedge osteotomy in a cadaver model and placed either 1 or 2 screws, both antegrade or retrograde. And we tested these on an Instron MTS. And in fact, we found, not surprisingly, that the difference between retrograde or antegrade, 1 or 2 screws, wasn't tremendously different, antegrade or retrograde, with a slight trend towards the antegrade being stiffer. And obviously with the number of screws and the stiffness at failure, we had slightly higher with 2 screws compared to 1 screw. So here's now a patient, thanks to one of my former fellows who is now doing this, Randy McKnight. This was 4 months after a anterograde shortening osteotomy, and the potential benefit here is that you're not disrupting the articular cartilage of the ulna by placing your screw retrograde through that articular surface. So the last thing I want to share is we talked about chronic LT injuries. I do think that the ulnar shortening osteotomy is also very effective in treating those problems. We talk about reconstruction using a slip of the ECU. We talk about LT arthrodesis procedures. But I think an ulnar shortening osteotomy is a very reliable procedure in taking care of chronic LT injuries. And the concept there is that With the shortening of the ulna lunate and ulnar triquetral ligaments are tensioned, and that stabilizes the interface between the lunate and triquetrum. And this has been borne out in this study by Athar Mirza and others, showing good outcomes after ulnar shortening osteotomy for chronic LT injuries. So I do think an ulnar shortening osteotomy is a great common final pathway for chronic and or acute TFCC injuries. I also use it for failed TFCC treatment. If you treat a patient with a repair or a debridement and it fails, a good bailout is the ulnar shortening. Obviously, ulnar impaction syndrome should be treated with ulnar shortening osteotomies. LT injuries and potentially distal radius malunions, you can argue to correct the distal radius malunion or to shorten the ulna. That's a topic for a different discussion. The results are reliably good. The new technique with cutting jigs really make this procedure faster and more reliable. And the complications do appear similar amongst techniques for the diaphyseal ulnar shortening. So I would submit to you that you may want to consider the metaphyseal ulnar shortening osteotomy as an alternative. So with that, I'd like to thank you for your attention and thank you again for the invitation to participate. And I look forward to taking any questions if anybody has any.
Thank you, Jeff. There was one question from the audience, and that was about the cast that you prefer for non-operative treatment for TFCC. Is it mainly just short arm cast like you showed, or a Munster? That was essentially the question.
Yeah, that's a great question. So theoretically, if you want to try to reduce the rotation of the forearm, you want to use a Munster cast or a long arm cast. But I'll tell you that you put a long arm cast on a patient, they're not going to be very happy with you. And so I've evolved to do basically what I call a long short arm. So I do a short arm cast right up to the antecubital fossa to really try to, with a good mold, to really try to prevent forearm rotation. But yes, theoretically and realistically, it should be a long arm or some variant thereof to try to maintain, to try to resist rotation. But patient compliance is really poor with those types of immobilization.
Absolutely. All right, we're going to transition now to Dr. Wayne.
All right, thank you, Jay. So let's see, hold on a second here. Everybody see my screen there? All right, I want to thank everybody for the invitation to AIL North America, and also Dr. Bridgeman, Dr. Yao for the great talks, and really excited to join this panel. Certainly feel quite young being a faculty next to our sage, Dr. Yao, so I feel a lot younger than Dr. Yao here. So I've been tasked with looking at complications of ulnar shortening osteotomy. Ulnar side wrist pain is a very broad topic, so I'm going to be following Dr. Yao's talk on treatment, really focusing on complications. As we look at ulnar carpal impaction, it's really any condition where you have increased load across the ulnar carpal joint. But it's also really important to recognize that you must make sure you have a differential in mind. Dr. Bridgeman went over a really great kind of overview of ulnar side of wrist pain. But we tend to focus on the x-ray. You see somebody with ulnar positive variance with direct impact of the ulnar head on the lunate. You kind of focus your eyes on that and you kind of forget about the differential diagnosis. Really like the Garcia-Elias kind of four-leaf clover algorithm. So anybody with ulnar side of wrist pain, I really want to look at kind of the entire picture. Is there a bony deformity? Is there a distal radius malunion? Are there arthritic changes between the sigmoid notch and ulnar head? Do you already have fairly advanced DREJ arthritis? Is there any joint instability? Is this a DREJ instability or impaction? Is there a central TFCC injury? And lastly, look at the ECU tendon. Perhaps the patient with ulnar carpal impaction, most of their pain is on the ECU tendon, so it's more ECU tendonitis, or perhaps an unstable ECU. So it's really important to keep that in mind and not kind of focus on the obvious when you see a patient in clinic. Dr. Yao gave a great overview of ulnar carpal impaction in terms of treatment options. I think overview looking at decompression of the ulnar carpal loading and articulation. It could be arthroscopic debridement, resection on our head, either arthroscopic or open wafer, and ulnar shortening osteotomy. I think it's really important to get to know the patient as far as their lifestyle, any comorbidities, and also patient compliance as well, and really what's important to the patient. I'm going to cover this a little bit in a couple of cases I'll be presenting, but it's also important to really look at the x-ray critically. Does the patient already have early onset or perhaps advanced DREJ arthrosis? So that really changes the treatment algorithm. Somebody with ulnar carpal impaction with no DREJ changes, you're probably looking at either wafer and ulnar shortening. But once you have fairly advanced DRJ changes, probably looking at some type of salvage procedure. This could be a distal ulnar resection, either a complete or a hemi, a salvage Kaponji, or some type of DRJ arthroplasty. It's really important to kind of keep that in mind. This is probably the largest clinical series that's been published by a single center looking at ulnar shortening osteotomy out of Pittsburgh. 164 cases, really impressive results, 99% union rate, 95% healed at 10 weeks, and they treated kind of a whole host of patients with different injuries, including central TFCC injuries, also LT ligament injuries as well. They look across the board, all comers, patients, pretty impressive results, great pain relief, great range of motion, grip strength is improved across the board. Really seems like the panacea for really ulnar-sided wrist pain. Dr. Bridgeman, Dr. Yale talked about doing ulnar shortening osteotomy, not just for impaction, but perhaps DRJ instability, perhaps for LT instability as well. Perhaps this is the solution for everybody. But looking at a meta-analysis, a systematic review that was done, complications are not uncommon. Non-union rates about 4% across the board, fairly similar whether you're doing a transverse or oblique osteotomy. If we kind of take it further, looking at delay unions, goes up to about 7 or 8%. So even though it's a great surgery, complication does happen. You are looking at fairly prolonged recovery process for a patient, looking at 3 or 4 months of activity modification until they return to activity sports. So definitely keep that in mind. Looking at other complications, not just non-union, hardware irritation, hardware removal, up to 72, 75%. So it's really important to have that conversation with the patient that this is likely going to be a secondary surgery that's going to be done at a later time point, 6 months or a year later. CRPS was also described in the literature in a couple case series. As you're looking at placing that plate more distally, especially that metaphyseal osteotomy you're looking at, especially if you're doing some type of hook plate, the dorsal cutaneous branch ulnar nerve is also going to be in the proximity. So make sure you identify, retract to make sure it's protected throughout the case as well. Certainly have patients also with more Guillen's canal or carpal tunnel symptoms post-operatively. It's also not uncommon. So what are some prognostic factors looking at union rates after ulnar shortening osteotomy? This is a large series out of Korea, 325 patients. Again, it's a great surgery, but it's really important to talk to the patient about potential complications, also a potential prolonged recovery process. About 10% of patients had a delayed or a non-union, even with prolonged mobilization, prolonged activity modification. I think smoking is really the biggest factor that's been attributed to looking at a delay union. Poor bone quality. So somebody who's osteopenic may not have the best bone for any type of ulnar shortening osteotomy device or technique, something to keep in mind. This article also talked about the heat from a double blade. So some surgeons will do it from a stacked blade, having 2 or 3 blades stacked on top of each other. I think it's really important to make sure if you are going to do this freehand, really judicious irrigation, make sure you keep it nice and wet and really make sure your cuts are nice and clean as you're doing your osteotomy. Smoking is probably the biggest risk factor. I think a lot of surgeries that we do in hand surgery, even for oftentimes a total wrist fusion or a limited fusion for patients who have severe pain and severe disability, oftentimes will still consider surgery. But this series out of Boston looking at smokers. So they actually have 40 smokers in the case series, and time to union went from 4 months up to 7 months. The non-union was actually 30%. So at least in my practice, somebody who is a smoker who's not able to quit. So even if they have fairly painful ulnar carpal impaction, probably looking at some type of arthroscopic wafer for that population and not an ulnar shortening osteotomy. So for me, it is an absolute contraindication. So complication looking across the board, non-union is probably the most important one to talk to the patient about. 5%. It's a big surgery, big exposure. If you look at the metaphyseal shortening that Dr. Yao described, it is a less invasive procedure, but I think you do lose the benefit of trying to stabilize the DRJ complex. And secondary surgery is not uncommon. Over shortening can lead to, I think, aggravation of DRJ arthritis if you're not careful, and neuropraxia. Wafer, I think, is a way around this. It's a lot easier. No concerns with non-union hardware irritation. You could perform it open or arthroscopically. Outcomes, I think, arguably are perhaps better, more from earlier recovery. Earlier on, patients do have better grip strength, better dash scores, and complications are less common. You don't have to worry about secondary surgery with implant irritation. But Dr. Yao kind of mentioned earlier, at least in my hands, ulnar shortening is much more reliable. In my hands, an arthroscopic wafer just does not do as well. You could certainly over shorten or take too much off and destabilize the DREJ, or you don't take off enough. So these are some of the things you kind of worry about. You can't resect more than 2-3 millimeters. Doesn't stabilize the DREJ complex. You could certainly have an incomplete resection or destabilization. So soft tissue complications, how do you avoid that? For the most part, I do place my hardware volarly underneath the FCU muscle. I think you have better soft tissue coverage. I think dorsal only, most people don't have a lot of soft tissue coverage over that area. But a study out of HSS looking at dorsal versus volar, really the main difference with the dorsal approach, they were able to get away with a much smaller plate. It's the tension side of the ulnar shaft, so a smaller plate with a 2.7 plate. At least in their series, the outcomes were much better by going dorsal with a smaller plate. Hardware removal was much less common, 12 versus 33%, and better grip strength. And they also had no cases of a non-union when they went dorsal, compared to 2 cases with a volar approach. I think technically there's certainly things that you could really kind of try and do better during surgery. Make sure you irrigate judiciously. Make sure you irrigate. Make sure you have clean cuts. I think a lot of times when you do it, often with a trainee, you'll see them kind of take that saw and almost push it really aggressively into the bone. Really make sure you're oscillating really nicely. If you're doing a freehand, the commercial system is really nice. Make sure you have 2 clean parallel cuts. But if your cuts are not perfectly parallel, oftentimes you'll find that 2 bony surfaces do not pose well. Make sure you have good compression. The lag screw, I think, is really helpful to really make sure you have good compression across the osteotomy. But I will argue that intraoperatively, if you feel like your lag screw does not have a good purchase, that lag screw actually causes almost a windshield wiper effect, can make your union site be at a higher risk of a non-union. And there are cases where you have really poor bone, poor screw purchase with osteopenic bone, that ulnar shortening osteotomy may have a fairly high risk of hardware failure as well. I think arguably the best clinical series I've kind of seen in the literature is still the series by Pittsburgh again. In their case series, 99% union rate. I think most clinical series, anywhere from 2 to 5% patients have a non-union, and delay union is not uncommon. But I think the benefit of a step cut osteotomy, it is a much bigger bony surface. So I would say as far as bony surface for bony union, step cut may be better than oblique, and I think oblique is definitely better than transverse osteotomy. The other thing to keep in mind, if you're looking at shortening, there are patients with a distal radius malunion or kind of chronic deformity from a childhood injury where your ulnar carpal impaction may be fairly severe. If you're trying to shorten 6, 7, 8, 9 millimeters or longer, I think you might want to consider more doing a metaphyseal shortening. The diaphyseal shortening, you're kind of fighting the DOB, you're fighting the interosseous membrane. So trying to shorten excessively is really, really difficult with a diaphyseal shortening. So patients we're looking at doing a pretty aggressive shortening, you might want to consider doing more of a metaphyseal shortening. The other thing to kind of keep in mind, I live up in Seattle where we don't see a lot of sunshine. So we get about 2 or 3 months a year. So vitamin D deficiency is a lot more common than people recognize. So patients coming in who had ulnar shortening osteotomy, X-ray looks great initially at 2 weeks, 6 weeks. You just really have no callus, no trabecular bone healing whatsoever. Make sure you do a full metabolic workup, vitamin D panel, thyroid panel. If you look at the literature looking at really fracture non-unions, if you do a metabolic workup, they found that about 60 to 80% of patients actually had a vitamin D deficiency. So really important to keep that in mind. Obviously, look at your infectious workup. I think patient compliance is also key. Somebody who does early weight bearing also had a higher risk of a non-union as well, and also implant failure. Look at a couple of cases and kind of how I dealt with the complication. 65-year-old female, 20-plus year history of worsening ulnar side of wrist pain. The ulnar head was fairly prominent dorsally, good range of motion. And she was 3 millimeters positive with cystic changes over the ulnar head and the proximal lunate as well. Kind of did a standard ulnar shortening osteotomy with commercial system. Intraoperatively, also post-op at 2 weeks. Pretty happy. Oblique cut, good bony opposition, good compression across the osteotomy. This is her at 3 months post-op. This is kind of your stomach kind of sinks. You see the back. Not only do you have really no healing, but you're getting increased lucency right where the lag screw is, right at the osteotomy site. The question is, what do you do? She's at 3 months, increased pain, increased swelling. What are your options for revision? I think, at least in my practice, I don't rush the revision surgery. Delay unions, I think, are fairly common at oftentimes it takes about 6 to 9 months, just being really patient with the patient, prolonged mobilization until it's healed. I think there is a role for a bone stimulator in patients who have a delay unit at 3 months. I really kind of recommend revision only if there's increased gapping or hardware failure for these patients. Brings into case number 2, 78-year-old male, severe pain. You can see pretty obvious ulnar carpal impaction, 3 to 4 millimeters positive. The ulnar shortening osteotomy. This is a patient that really kind of poor bone quality, poor purchase with lag screw, good bony apposition. And 2 weeks post-op, complete kind of instability at the osteotomy site. So we actually looked at kind of a technique for addressing this recently, case series. We've done about 4 cases now using stable fixation. The concept is you want to get better compression. You also want to get 90-90 fixation across ulnar shortening osteotomy. So case number 1, we kind of went in there, cleaned up the osteotomy site, applied a compression stable across the osteotomy, followed by a neutralization plate. Case number 2, kind of same technique as well. So I think this is a kind of good salvage, gives you excellent compression, also 90-90 fixation across the osteotomy as well. Reversible obliquity, Dr. Yao talked about this. Is this real? This is something that's more something you see radiographically, but clinically, not something you worry about. So this study by Maureen O'Shaughnessy with the senior author, Dr. Yao, looked at this. 1,000 radiographs found out reverse obliquity, at least radiographically, about 6%. In patients either with the oblique sigmoid notch or reverse obliquity, DRG arthritis is much more common, so something to keep in mind. So it brings me this patient here that had multiple procedures done elsewhere over the last 10 years, came in, ulnar shortening osteotomy, really severe DRG arthritis. Was it something that perhaps was made worse by the ulnar shortening osteotomy, or is it something that was maybe not recognized initially with the initial injury, initial condition as well? For a patient like this is a workers' comp patient, 2-year history, ulnar side of wrist pain, kind of classic MRI changes combined with LT ligament injury. We decided to go down the ulnar shortening path to address the impaction plus instability as well. Then a shortening osteotomy, 6 months post-op. The shortening osteotomy is healed. Unfortunately, it is a workers' comp patient. Now he's saying that the ulnar side of wrist pain is much worse. Radiograph on the left is initially at the 3-month post-op time point. Now the 6-month DRG arthritis is much worse now. Severe crepitus on DRG allotment. He's been off work for 6 months now. They decided to do a distal ulnar hemi recession with a meniscal interposition and kind of a Sanj calamari. 3 months post-op, he's thrilled. He's really happy. Decent forearm pronation supination. Now, 6 months later, now he's miserable again. Now he's got severe pain over the DREJ, increased crepitus, increased instability. We end up going down the DREJ arthroplasty route. So I think in summary, I think ulnar shortening osteotomy is a great operation. It's a great solution for a lot of ulnar side of wrist pain, but certainly not the right surgery, the right solution for everybody. It's important to counsel the patient about potential complications. Ulnar a hardware irritation, hardware removal is not uncommon. Non-union rate, certainly a lot of things we could do better. I think technically a lot of things that could be done better. Really pay attention to your technique intraoperatively. If your technique is good, but they have a non-unit, consider a metabolic workup. For patients with revision, I think 90-90 fixation is not a bad idea. Getting better compression, better stability, and beware of overshortening or unrecognized DRG arthritis. And that's all I have.
All right, thank you. We did have some questions, didn't we, Dr. Yao? Do you want to go over a couple of the answers that you had just for the rest of the audience?
Sure. I think one of the questions was, would you do ulnar shortening if there's any degree of DRJ OA? And I think Jerry did a nice job discussing that. I think you have to be very careful with that. I do think that if there's mild to even moderate DRJ arthrosis, you could still consider an ulnar shortening osteotomy. But once it gets to the point where it's more significant, i.e. the patient has crepitus on rotation and or when you do a DRJ allotment, you feel grinding or crepitus, then I might consider doing a more of a salvage procedure for the DRJ, but at the same time, offload the ulnar carpal joint. Jerry, do you have any thoughts on that?
Yeah, I think I agree. I think there's sort of a couple of clinical series out there on really mild DRG arthritis. I think an ulnar shortening can actually address that. You're basically changing the contact between the ulnar head and sigmoid notch But once it's fairly severe, I think you're looking at some type of salvage procedure. I agree with Dr. Yao as well.
I think another good question is how much do you shorten? Do you go for neutral? There's good work to suggest that only offloading 2 millimeters should be sufficient. I'm aware of that literature. For me, I like to get it neutral or even slightly negative if I can. And that's mostly because, 3 months down the road, hey, the patient's feeling great, but you know what? They're looking at the x-ray. Why does that bone still look a little bit longer than the radius? And so, I don't have a problem with just someone who would argue for shortening just 2 millimeters, but I like to get them neutral or even negative. What do you think, Jay and Jerry?
I agree.
Yeah, I agree. I like to go neutral, especially a lot of patients are only 2-3 millimeters positive. I feel like they kind of look at the x-rays kind of post-op in clinic. They feel like you didn't do a lot of shortening with a big procedure. It's always nice to make sure you're neutral, maybe 1 millimeter negative, so that you feel like you really did a lot for the patient.
Yep. Another question was what type of nicotine? For me, any nicotine, even the nicotine gum, which is kind of a bummer for the patient because they'll try to quit and they'll try to use like a Nicorette or some other nicotine gum to try to help them quit smoking, but it's the nicotine that's still the problem. So I won't do an ulnar shortening or wrist fusion or any partial wrist fusion if anyone's doing any of that stuff. Including cannabis, although I know that's relatively controversial. But Jay and Jerry, what do you think about that?
I do nicotine cotinine testing for the same reasons. I tell them I'm not going to do an elective fusion if they're nicotine positive, and then I make them. They don't need to be 6 weeks negative, but I make them. I won't do the testing until they tell me they've been 6 weeks negative, and then I do nicotine cotinine. If it comes back negative, then I say, okay, good, we'll put you on the OR schedule. But I've had patients come back 3 months afterwards, everything's healed. They say, I feel a lot better. I'm not smoking anymore. I never went back to smoking. So you get that secondary benefit too.
Yeah.
I agree. I think this is one surgery I will not do on a smoker. I think this is the one indication for arthroscopic wafer in my hands. But total wrist fusion, I'm probably a little bit more relaxed. I feel like the union rate's much higher with that particular surgery. I think as long as they're not smoking 2 packs a day, I am a little bit more relaxed on a total wrist fusion.
I think that's really great. Why don't we transition for Wendy Moore's section, and then I've got a couple of questions at the end that we can go through as well.
Great.
All right. Good. Can you see my screen? Great. All right. So I'm Wendy Moore. Thank you for having me be here. I'm a hand therapist. I'm going to speak on rehab for ulnar-sided wrist pain. I'm going to focus on ulnar shortening osteotomies because that's been the focus of our talk today. But a lot of the things I'm going to discuss can be kind of carried over to some of the other procedures and TFCC repairs, things like that we have talked about today. All right. So as we mentioned, consideration of a rehab program does typically start with a period of immobilization. And we talked about how Munster and sugar tongue splints, as we know, that go above the elbow, are the most effective at limiting rotation. And I was glad that Jeff alluded to this, that sometimes we can also use an ulnar gutter wrist orthosis or a volar wrist splint to also limit some rotation. And these are better tolerated. So there was a study out of Korea that did show if you extend the orthosis to about 2.5 centimeters of the antecubital fossa, you can capture the PRUJ and some of the forearm muscles. So therefore, you can limit some rotation. And as we mentioned, this is often better tolerated than the Munster sugar tongue splints. For ulnar shortening osteotomies, majority of studies do describe a period of immobilization, usually of about 4 to 6 weeks. So at this time, usually some studies describe limitation of rotation for the first 2 to 3 weeks, and then transitioning just to a basic wrist splint for another couple of weeks. Once we start to get these patients moving, we can consider, do we need to, at this point, we can look at, do we need to limit any rotation moving forward, as far as some studies limit pronation and supination for up to 8 weeks when they start mobilization. So we may consider starting in the dart thrower's motion plane and take advantage of this mechanical axis of movement. This is the greatest total range of motion of the wrist, and it's also a safe movement early on because of the minimal muscle force required to move in this plane. It's also, as we know, our most functional plane of movement and how we do a lot of things like drinking, opening a container, pouring water, things like that. In this mobilization phase, we might also consider some proprioception training to reestablish the feedback provided by the mechanoreceptors in the wrist and the role they play in dynamic wrist stability. So we know when we have a wrist injury, the sensory motor pattern is altered, and we especially know this to be true for TFCC injuries. Hager and others have shown that there is value in a sensory motor rehab program following trauma in other joints. And we know that with ankle and knee, sensory motor retraining is standard in the rehab process. So something we can consider in our treatment of these wrist injuries as well. And finally, once there's some evidence of bone union, patients may progress through a strengthening program. So we may consider starting with isometric strengthening, progressing to isotonic exercises, and then eventually getting to weight bearing and more powerlifting, things like that. We may also consider strengthening of the pronator quadratus and the ECU, as we know these muscles to have an important biomechanical contribution to DRUJ stability. So if that's a factor, that might be something else we want to keep in mind as we do our strengthening program. So I pulled a couple of studies specifically for ulnar shortening osteotomies that I just want to talk about and kind of how they can help guide some of our practice. So this was a recent study. It's a small study out of the UK from 2019. It was published in the Journal of Wrist Surgery. And I thought it was an interesting study. They were trying to answer the question, does early active mobilization affect the rate of union following USO? And does early active mobilization affect the rate of complications following an ulnar shortening osteotomy, like we just talked about? These patients, it was a small retrospective review. There were only 15 patients, underwent 16 USOs, and they were placed into a half cast or just a post-op dressing until day 12. At that time, the dressings were removed and they were not placed in any further immobilization. So the patients were started on a hand therapy program. They did follow up until radiographic and clinical union were achieved. And in the study, they found the median time to union was 14 weeks and they had 100% union rate. So this is like pretty consistent with the literature as far as the time to union. So I thought that was just an interesting study to think about. And then another study, again, we think a lot about when these patients can return to work. So this was a study out of the Netherlands. It was just published in 2022. It was a retrospective cohort of 111 patients who underwent an ulnar shortening osteotomy. They completed a return to work questionnaire at 6 weeks, 3 months, 6 months, and 12 months after surgery. This study was interesting. They did describe a complete rehab program. These patients were immobilized in a Munster splint for 4 weeks, and then they were limited in any rotation for 8 weeks with strengthening and load bearing starting around the 8-week mark and power training at about 3 to 6 months. So they did describe the rehab program these patients underwent. 92% of patients returned to regular work in the first year, but half of these patients actually returned to work within the first 12 weeks. So I thought that was pretty standard with what we see. Obviously, there were large variations in the timing of return to work based on the type of work. So heavier, manual labors were a little bit longer for return to work. So just some final thoughts. I think it's important that we consider how much immobilization we need. So again, if we're dealing with TFCC or DRUJ instability or those kinds of things, our immobilization may need to be longer. We may need to consider above elbow. We may be able to get away with kind of a long volar wrist splint. Otherwise, for that one study, might be even something to consider depending on what else is involved if we can go with no immobilization. Usually, like I said, we like to start in the dart thrower's motion plane. We might add a sensory motor program to our toolbox. I think that's a good thing to have. And then finally, if we're looking at any kind of concerns with DRUJ instability, we may consider strengthening of the pronator quadratus and the ECU. That's it. Thank you. Here's my references.
Thank you, Wendy. Wendy, do you have much experience with some of the orthoses that are more like a strap around the wrist? Like, do you have any ideas, comments about a strap versus a custom thermoplastic device for?
Yeah, absolutely. I think, we usually start with, kind of the most rigid immobilization and work our way down. So, you can start with the Munster sugar tongue, then work your way down to a wrist brace. And finally, you end up with like the wrist widget or, something like that. And I think those are great as patients are returning kind of back to work or back to sports or things like that. There's a place for those kind of softer wrist wrap braces that I think can be helpful for sure.
Kind of like for final transition to full activities.
Exactly.
Some of the questions I had for our other faculty tonight, for the wafer procedure, I don't feel like I'm good at an arthroscopic wafer. Have either of you done open wafer? And if so, what's the approach that you would be able to access that to do an open wafer?
If I'm going to do a wafer, which again is very, very rare, I'm doing it arthroscopically. I think if I'm going to open it, I'm just going to do a metaphyseal ulnar shortening osteotomy. If I'm just going to open it at that level. So if you want to do an open wafer, you just go, I think the best approach is a dorsal approach through the floor, the fifth compartment, and open your DREJ, identify the ulna, take an osteotome or saw and cut out that portion. I think that'd be a reasonable way to do it. But to me, that just sounds very destructive. And if I stay just a centimeter or less below that and make my osteotomy through the neck of the ulna, then I can preserve the entire articular surface of the ulna and then do my closing wedge osteotomy. So that's my preference. But if I was going to do a wafer, I would do it arthroscopically.
Yeah. And the metaphyseal, I was just going to ask real quickly before, Jerry, the metaphyseal osteotomy, that's done through a subcutaneous, like the subcutaneous border of the ulna approach, like straight ulnar, or how do you get to, what's your approach for that?
No, I also do the straight dorsal through the floor of the fifth compartment. In that case, I don't violate the DREJ capsule. I'll make my osteotomy just proximal to the DREJ capsule because mostly now I'm doing the antegrade screw. So I do a closing wedge osteotomy, close it down. I use a clamp to hold it closed and compressed, then put a guide wire for a cannulated headless compression screw from the ulnar cortex up into the corner of the ulnar head, then put your screw in. That way you don't violate the DRJ capsule, you don't violate the articular surface of the ulnar head.
Very cool. And Jerry?
Yeah, so for my wafers, I do arthroscopically. I think you are limited by how big their central TFCC tear is. I've had cases where you go in there, they have impaction, they have cystic changes on the proximal lunae and ulnar head, but the TFCC tear is actually pretty small. Those cases, I feel kind of guilty, kind of debriding the entire TFCC just to get to the ulnar head. In those cases, I do an open wafer. I think arthroscopic is the way to go. But if you haven't done a lot of arthroscopic, it's really critical if you do arthroscopic wafer to make sure you rotate the forearm through pronation and supination. Otherwise, you end up missing anteriorly posterior if you don't do a full rotation of the ulnar head as you're doing this. But yeah, if I do an open wafer, similar, I do a floor of the fifth compartment, open the DRJ capsule, make sure you stay below the TFCC so you don't actually cause further injury. You just take an osteotome and kind of make that little wafer cut on there. It's a pretty quick surgery.
Nice. And then I was curious, Jerry, about the revision cases that you showed. Those were great. For the staple technique, do you use bone graft? Like if you're going back, they've already had a non-union, you're revising it. Do you bone graft the revision? Do you do autograft or anything, maybe augmentation with other things?
Yeah, I think all depends on, I guess, how much ulnar variance I achieve with initial surgery. So if I'm at neutral, then I actually rather make a clean cut and compress a little bit more. So I end up being maybe millimeters ulnar negative. In that case, I don't bone graft. I like the staple because it compresses really, really well for me. For cases where you're trying to go back and compress it again, especially you've made the osteotomy, kind of clean out some of that fibrous tissue. I feel like just putting another neutralization plate on is probably not enough. That's why the staple's been nice for me. But if I'm at neutral or 1 millimeter negative and there's a pretty big gap at the non-union site, then I will do bone grafting. I will do some type of cancellous bone grafting for that defect there because I don't want to overshorten. So now they're 3-4 millimeters negative. So if there's a big defect, I will bone graft. There's not much of a defect. I'd rather do a clean kind of bony cuts on there and just do a compression plating.
Thank you. I think when I think back to some ulnar non-unions I've taken care of, they weren't for ulnar shortening. They didn't have a surgery. It's mainly for like a both bone forearm where the ulna didn't heal, radius did. I had one lady that had an infection. I had to go and treat that first. And those had more of a significant loss of the ulna, not a lot, but they had some. And I ended up doing a tricortical strut from the iliac crest, and then just did standard compression plating across, a tricortical strut that I bring it back to healthy bone and put that in and compress, traditional compressing and get that. And I've had good success with that, but that's a little bit overkill for this setting. I like the idea of this staple technique is really fascinating. I like it. Do you all cast for 4 weeks after your ulnar shortening osteotomy?
So I'm pretty careful with these. I splint for 2 weeks, kind of similar to Jeff, a very long short arm splint coming out of the OR. They do go into cast for me for another 4 weeks. I don't start moving them until they're 6 weeks out. I know some people move them pretty early on, but for me, I'm still pretty careful with these because I have had quite a few delay unions. So I'd rather be a little bit more careful.
Yeah, I agree with that. I think it is something that's concerning. So this actually points to one of my favorite studies that I did, but didn't really get a lot of press. It was a study where we polled the membership of the ASSH, and we asked them, how long do you immobilize a patient after you fix a distal radius? How long after you fix a scaphoid? How long after an ulnar shortening? How long after a four-corner fusion, et cetera, et cetera? And it was all across the board. And when I trained, we immobilized our ulnar shortenings for 8 weeks because we were concerned about the non-union, and patients hated being in a cast for 8 weeks. And so after this study, it was all across the board, and there was a good cohort of people who were just doing 4 weeks. And so for me, that gave me showed me that it's all dogma and it's all voodoo. Nobody really knows. There's really not a lot of good literature to support one way or another. And it gave me the confidence to go shift from 8 weeks down to 4 weeks because people were doing it and presumably having reasonably good results. So now I just immobilize for 4 weeks, as long as you have good compression across the osteotomy, which you should have. But I don't disagree with Jerry that the concern here is that you're using a saw and the thermal necrosis on a bone that doesn't have a lot of good cancellous healing capacity, and you're stripping the periosteum to get your plate on there. So you're really disadvantaging yourself. This is not like a fracture situation. And so the healing rate or the potential for healing is compromised. And so that's why immobilizing longer is not a bad thing, but I do 4 weeks and I haven't had a problem.
I also do 4 weeks and then make the decision based on the radiographs at 4 weeks. If it looks like the osteotomy is starting to heal across, you see some crossing trabeculation, then I feel confident to go forward and lessen immobilization. And then how about oblique osteotomy versus transverse? I'm an oblique osteotomy person. Either of you have some patients you do a step cut, others you don't. Any ideas about that?
Yeah, I know Jerry showed that paper. I think that makes a lot of sense. It maximizes your surface area for healing, but I'm not good enough to make a step cut fit exactly like a puzzle piece. Jerry's a much better surgeon than me. I like to use the jigs, and they make a nice oblique cut, and the oblique cut has a little more surface area than a transverse cut. So I like an oblique cut with a lag screw across it, and that seems to work for me.
Yeah, I mean, I think commercial systems certainly makes it a lot easier. The cuts are perfectly parallel. You get great compression. A step cut's nice if you want to kind of do something that's kind of cost savings. I haven't been brave enough to do so, but at some point I'm tempted to do a step cut and do 3 lag screws and be done. Because I think people worry about the hardware irritation from a big plate, and we do it in other parts of orthopedics with pelvic osteotomies, other stuff. But I think at some point I might consider doing a step cut and lag screws only. So I haven't done it quite yet.
Yeah, I would just say the thing that comes to my mind is that lag screw is to always use the tap before you put the screw in. We don't think of tapping holes because they're self-tapping screws, but this is one where I would actually tap the far cortex before I put the screw in. So that you maximize the bite that you're going to get. The other thing that comes to my mind is that failure that comes to my mind is just the bone quality. Like if it's an older patient, maybe they have osteoporosis, osteopenia. Those pre-manufactured systems are not necessarily very long plates; they're pretty short, and so I might consider having to do some a freehand system versus and using a longer plate in order to get better fixation essentially across the zone of the osteotomy. Any other questions? We're really wrapping up with time here. Any other comments or questions from the faculty?
So Jed, if Wendy wants to answer a couple of questions in the chat box about different splints for ECU tendonitis. Kind of talked about ulnar boost splint as well.
Yeah, please bring those up.
Wendy's thoughts on kind of the boost splints for perhaps LT instability, and also how you address splinting for ECU pathology.
Great. Yep. So I've been recently making more of an ulnar gutter type wrist splint, and in that sometimes there was, I'm forgetting who wrote the paper, but there is an example of kind of making a self-made little boost splint where you can kind of help kind of put in a little extra pressure over the pisiform and create a little bit of a boost. So sometimes we do that. Otherwise, for ECU, I've been making more of an ulnar gutter kind of wrist splint just because I feel like I can get a little more support on the ulnar side as compared to just throwing them in a prefab or even a custom wrist splint. I do like the wrist widget or the bullseye. I think patients do tolerate those very well, and they're very easy to wear. I know Push also makes a kind of wrist wrap that some people like as well that provides a little bit more support. So I think those are also good options. The other thing I like for ECU tendonitis is taping. So we do kinesio taping, and I find that can be also helpful to address the ECU tendonitis.
All right, I think that about covers it. I want to say thank you for everyone tonight, for all the faculty and for the AO staff that helped us put this on. And we hope to see you guys next month for our next 3-case Fireside series. Good night.